Hello, my name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN Project. And thank you all for joining us today and our friends at Cherokee for us hosting today's session, All About Insulin with Dr. Margo Hudson. Dr. Hudson is an assistant professor of medicine at Harvard Medical School, where she has practiced for nearly 40 years, specializing in endocrinology with an emphasis on diabetes. In more recent years, she started the Polycystic Ovary Syndrome Clinic at Brigham and Women's Fish Center. She's interested in the medical treatment of obesity, as well as thyroid problems and osteoporosis. She has volunteered extensively in the under-resourced areas, both internationally in Cambodia and in New Mexico at the Gallup Indian Medical Center, helping with their diabetes centers. She's particularly interested in provider education through on-site teaching and virtual lectures. In 2021, she received the Department of Medicine Exemplary Service Award for her work. It's a pleasure to have you here today, Dr. Hudson. I'll turn it over to you to start sharing your screen.
Okay, great. Thank you, Jill. Let me see if I can get this to work. And we're going to go here. There we go. How is that? Is that showing up as a full view for you guys?
Yes, that looks great.
Excellent. Okay, so this is going to be a little bit different than I think you will have been used to, but hopefully you will find this kind of interesting and informative. So I don't have any disclosures. I do want to say sometimes we have to use branded names, especially about some of these products, because that's kind of how you're familiar with them, but none of this is an endorsement of any particular product. And here are some of my other slides for MAVEN. So I want to start in terms of talking about insulin therapy with just remarking on the history. It's been now at this point a little bit over 100 years since insulin was isolated from beagle pancreases. And it was done by these two, Banting and Best. Everybody's heard about them. There were several other people involved in the isolation of insulin, and they don't get enough credit. And there have been a lot of interesting books written about the wrangling between them all. So they isolated insulin in 1921, and they gave it to their first patient. Here he is, Leonard Thompson. In 1922, he went from being really on the verge of death to being a more robust teenager. You can see, unfortunately, he did have a very shortened lifespan, but this was the start of using insulin for diabetes. So where does insulin come from? And naturally, it comes from the islets. The islets are in the pancreas, and they're made up of multiple cell types. Alpha cells, beta cells, and delta cells are the most abundant cells in the islets. They actually have a very defined structure, and there is a relationship between the beta cells, which produce insulin, and the alpha cells, which produce glucagon. And so it isn't really random. It's really quite complex. So what is involved in insulin secretion? Many of you may not have reviewed this since you were in medical school or nursing school, but glucose is transported into the beta cell by the GLUT2 transporter. And there it is metabolized, and the metabolism of glucose increases ATP in the cell, which this is a little bit backwards. Increasing the ATP level, or the energy in the cell, closes this potassium channel. Now this channel is where sulfonylurea agents work. They close it independent of ATP levels. But in the natural state, ATP goes up, this closes, that depolarizes the cell, calcium comes into the cell, and it stimulates the insulin to be released. But it is a little bit more complex than that, and I wanted to put this on because everybody has heard about GLP-1 and now GIP and some of the analogs that bind to these receptors. And so where do these receptors fit in terms of insulin secretion? So you can see I put these two here, the glucagon-like peptide 1 receptor here, where semaglutide, liraglutide, and actually dulaglutide, they will bind there. Then the GIP receptor used to be gastric inhibitory peptide, but they have changed the name, and I never can remember the new name, but that receptor is here, and tirzepatide, the newest one, impacts both of these. They also work to change the energy in the system. But if the ATP, potassium ATP channel is not closed, they really don't enhance insulin secretion. So that's why there's no hypoglycemia with them. And they help cause more insulin to be released. So once insulin is released, what does it do? It binds to its receptor, and that triggers this whole cascade of enzymes that lead to the GLUT transporter 4, which is in the cell of the insulin responsive tissues, and the GLUT transporter 4 goes to the cell membrane and it sucks glucose in. So GLUT4 is present on in adipose cells and muscle, and that's how they bring glucose into the cell. So what are the actions of insulin? Insulin does more than just transport glucose. So here we have the effects where it enhances glucose uptake, glycolysis, glycogen synthesis, protein synthesis. And everybody, like, you don't think about it, but you do know, of course, that in patients with hyperkalemia, we give them insulin because that will help lower the potassium level. So there you go. It also stops multiple processes. It stops gluconeogenesis, glycogenolysis, which is breakdown of glycogen. It stops lipolysis, ketogenesis, and protein breakdown. So those are the main actions of insulin. So what is the molecule? I don't know if you realize, so it starts out as proinsulin. Okay, this long chain, and then in the endoplasmic reticulum, it gets processed. This part gets cut off. Here it's called the C chain. You may know it as C-peptide. C-peptide is produced in equimolar amounts to the amount of insulin. The insulin then has an A chain and a B chain. And just hang in there with me because there is a reason to know all this about the structure of insulin. And it's held together by disulfide bonds and stored in the insulin granules, waiting for the signal to be released. And this is the structure, the actual amino acid structure of human insulin. Here's the A chain. Here are our disulfide bonds. And here is the B chain. And in biologic systems, as well as in an actual vial of insulin, this insulin, to stay in solution, to not crystallize and drop to the bottom, has to be maintained as a hexamer. That means 6 insulin molecules kind of bind to a single atom of zinc in the center, okay? And that is how commercial insulin is made, and that is how insulin is stored in granules in the beta cells. And I'll just point out one little thing here. You see proline and lysine, and if you think about it, you would say pro-lyse. Oh, what does that sound like? Maybe lyse pro. Anyway, I'll show you that in a second. So that is the structure of human insulin. Now, one of the big issues is when we give insulin to patients is how do we get it from our vial into the bloodstream to do all those actions? So it has to be injected subcutaneously, and from there it has to be absorbed. So this is just, I think, a nice schematic showing you. Here we have our insulin hexamer, 6 molecules of insulin. It doesn't show you the zinc in the center. This by itself is very hard to absorb, and so it's very slow. If it breaks into dimers, so 2 insulin molecules together, it will be absorbed more quickly. And monomeric insulin, just insulin that's lying around by itself, can be very rapidly absorbed. This is like for rapid insulins, we're always looking to try and see, can we create monomeric insulin? So I don't know if you've ever asked this question to yourself, what is a unit of insulin? We all know, okay, it's 20 units. We're going to give 20 units of insulin. What does that actually mean? So if we go back to our history lesson, they had, once it was clear that you could isolate insulin from a pancreas, and they went to commercial production of using cow and pork because those were available from slaughterhouses. They needed to know if how to compare the product made by one company compared to another. And so they said, how do we decide that? They couldn't actually measure insulin until the 50s or the 60s. So they decided that it would be the amount of insulin. 1 unit is the amount of insulin that reduces the blood glucose in a fasting rabbit to 45. Like, who thought, these poor rabbits? So how much insulin that it was, the amount of insulin to make a rabbit hypoglycemic. And that became 1 unit. So it really was a biologic test. Later, when they were able to actually isolate and crystallize the insulin, it turned out to be 34 whatever micrograms of crystalline insulin. Now, however, I'll start showing you, we have all these newer analogs, and so molecular weight for 1 unit can vary. And the other issue is if the analog insulin binds the receptor differently than the natural insulin, it may need more or fewer actual molecules to create your same effect of being the equivalent of lowering the blood glucose in a rabbit to 45. So how do currently available insulins differ? And again, I think you may be aware of this, but we have structure. The structure can vary between the kinds of insulin. So we have human, so I showed you that, but then we can change the structure, and that is called analog insulin, and I'll show you some of the structure of some of the analogs. But we can also change the concentration, how much insulin is in cc. So our standard insulin is 100 units in 1 cc. That is why it's called U100. I don't know if you've even noticed this. There's U200 insulin, which Tresiba and one form of Humalog come as U200, U300. If any of you have used Toujeo, you'll know that's U300, and U500 is human insulin. U500, very concentrated, 500 units per cc for very insulin-resistant patients. So if we make changes in the structure, what does that do? So the difference is, the main reason all these big pharmaceutical companies are working on new types of insulin is it affects the absorption. Most of the structural changes affect absorption. The action is changed. It's actually, I should change this. Insulin action on the receptor is different with levemir, but now there are going to be some newer ones that will also bind to the receptor differently. The more rapid acting the analog, the more likely it is to remain as monomers and dimers to increase absorption. The long-acting analogs kind of aggregate together to prolong absorption, okay? And they also can have changes to affect their time in circulation. So they might have a longer half-life in the bloodstream. So getting back to this concept of the hexamer, which is the stable in solution insulin with zinc in the center. If we go to the dimers or the monomers, we get a more rapid acting insulin. If we go to dihexamers or multihexamers, we get a longer acting insulin because it takes longer to absorb. Just so you understand, it's primarily related to the absorption from the subcutaneous tissues. If you gave these things IV, they would all be acting pretty much the same. So the very first altered insulin was not altered so much, but it was had protamine added to it. So if you take regular insulin, you add protamine, you have neutral protamine hagedorn or NPH, and that way back in 1936 was found to have a slower peak and a longer duration of action compared to regular insulin. And so it could be given to last overnight. And it revolutionized management to have a longer acting insulin. Now we have all these different structures. I pointed out, so these are the most rapid acting analogs that we have, and where are the changes? They're pretty much always, you'll see one theme is that the companies are primarily changing the B chain. There are a few that have A chain changes, but Lispro, I pointed out before, so now it's Lispro instead of ProLis. They just switched this and it makes it more rapidly absorbed because it becomes dimers. Insulin aspart, you can see, and glucosine is not used so much anymore, but also substitutions in amino acids. What about the basals? First of all, I just want everybody to be aware. I don't know how many of you are using Detamir. I know some sites actually prefer Detamir because it was less expensive. It is no longer going to be produced, and so you are going to need to switch all your patients. So we can just see as a concept, what they did with Detamir is they add this long chain at the end, and it did affect absorption and circulation time. It stays in circulation longer. It also binds to the insulin receptor less effectively. And here we have glargine, one of the few that changes the A chain. Mostly it's changes in the B chain. So this gives us these different insulin action profiles. And you can see we have the long one, glargine, Detamir, that is going away, NPH regular, and the rapid acting. And again, it's on the basis of the different structures, whether it is more dimeric, monomeric, that's faster. If it doesn't, if it stays as hexamers or multi-hexamers, it's slower in terms of absorption. So now some of you may or may not be familiar with the newest long-acting basal insulin called Degludec. Again, it has this seems to be a theme. I don't know if you can see my arrow. I hope you can. This seems to be a theme in terms of drug development, that when you add these chains at the end of the B chain, it will slow it'll prolong the duration of action. So this is Degludec, also known as Tresiba, and it's a very interesting molecule. So I just think this is kind of cool. So for those of you who have seen the Terminator 2 movie, you'll know you would break him up and then he would all get back together again and go on his merry way. Well, Degludec kind of does that. It is floating around. You can see the zinc is like in the center of these hexamers. But when it is injected, it has this phenol in it that allows it to assemble into these long multi-hexamer chains. So the phenol will help get these hexamers lined up. So what does that do? That really, really prolongs the absorption. So this is a self-assembling. I mean, it's kind of, like I said, it's kind of like Terminator 2. It kind of assembles itself after it's injected into these long chains. And what that means is it has a duration of action for more than 42 hours. These are type 1 patients, so no endogenous insulin. You give them the Degludec, and you let them sit around and you see when does their blood sugar start to go up. Maybe a little bit of loss of activity. A few of these patients have blood sugars starting at 36, but it really takes close to 42 for the blood sugars to rise and the insulin action to be very low. So there you have it. And they've tried using this in patients, especially some of our more non-compliant patients who don't know what to do if they're on their Lantus and they miss their Lantus dose at night. Can they take it in the morning? And they don't know how to do it. And it's very hard to advise people because of the overlap and the stacking if you do that with Lantus. But what is so amazing with Degludec is they even did a study where they would have the patients take it in the morning one day, take it in the next day, take it the next morning. You could see they did this crazy thing that some of our patients would do. Same dose all the time, same dose all the time, and they didn't get into trouble. So here's A1C, comparable A1Cs, and comparable numbers of hypoglycemic episodes. So I would say, I kind of go to this particular product in patients because you can advise them, okay, you forgot your insulin at night. You wake up in the morning, you say, oh my goodness, I forgot it. You can take it. Don't worry about the dosing.
Dr. Hudson, a question.
Yeah.
Is zinc needed for the pancreatic storage of insulin?
Yeah.
And does a zinc deficiency affect diabetics?
So that's an interesting question, and I don't really know. I don't know if you can get that zinc deficient, that you can't get enough in there for the granules, but that would be really something interesting to look at. I do know that one of the antibodies or one of the targets in type 1 diabetes, for example, is the zinc transporter. So if you make antibodies to the zinc transporter, it kind of helps destroy the beta cells. But severe zinc deficiency and whether it would interfere with production and secretion of insulin would be really something interesting. I think we could predict that maybe it would, but I don't know if you would get a lot more symptoms before that. It was zinc deficiency. I don't know where else it's important in
Great.
metabolism.
Thank you so much.
Okay. Anyway, really good question. We'll all have to go look that up to see if you can get deficient enough to impact or impair insulin secretion. So this is the newest one, is once a week insulin icodec. And so here again, you've got the A chain and the B chain, and you have this very, very long tail that gets added on. So what does this do? It causes it to really be tightly bound to albumin. It changes its affinity for the insulin receptor. So going back thinking, if it doesn't bind to the set, so it has very low affinity for the receptor. It has very long circulating half-life. And so they are using it in phase 2 trials for once-a-week administration. And this is a relatively recently published article in New England Journal comparing daily dose of glargine to weekly dose of icodec in type 2 patients. And you can see very comparable glycated A1Cs, and this is CGM data after 52 weeks with glargine versus the icodec. The time in range with the icodec was actually higher than the glargine, and after 78 weeks, similar results. So this is not on the market, but I think all of us could imagine patients that would benefit from being given weekly insulin injection. You could give them their weekly GLP-1 and their insulin, and hopefully that would be enough for patients who struggle to take their medications. Okay, so just what does premixed insulin mean? I don't know how many of you using premixed insulin. So I always actually used to think there were 2 different types of insulin, but it's not. It's only one type. It's either regular aspart or Lispro insulin. These are the names that you would maybe see. But instead of adding protamine to completely bind the insulin like NPH, they add less protamine so that some of the rapid-acting insulin is free and can get absorbed more quickly. So just so you know, and this gives you an idea of how, like with the Novolog, with the aspart, you have a quick peak and then a prolonged duration of action. And Novolin, again, it's not as quick because it's regular insulin and a longer duration of action than human regular. So just trying to keep track of time to switch gears a little bit in terms of how to use these drugs. So just to go over, I think many of you have seen this slide before, the natural history of type 2 diabetes. So we go back in time for any person when they had normal beta cell function and they were not insulin resistant, right? This is our starting point. Their insulin resistance was normal. Their insulin secretion was normal. Their blood sugars were normal. Then as they age, maybe gain weight, they become more insulin resistant. And unless actually they lose weight, that insulin resistance will persist for the rest of their lives. And initially, the beta cells can gear up and produce more and more insulin, and that keeps the blood sugars relatively in the normal range or the pre-diabetic range. And then they reach a point where the beta cells are not able to continue secreting. So unlike insulin resistance, which stays stable as we age, the number of beta cells decreases with time, so that as we age, we have fewer beta cells. The ones that we have can get tired, or we call that glucose toxicity, and they are able to secrete less insulin. And in that setting, both fasting and postprandial blood sugars go up. So this kind of is what we see in the process of type 2 diabetes: persistent insulin resistance and decreasing ability to secrete adequate insulin, resulting in hyperglycemia. So when you're thinking about starting a patient on insulin, we have a lot of considerations. So would you just get a new patient and start them from day one on insulin? So we've all been confronted with patients like this. A lot of times the patients actually are in the hospital because they get admitted with hyperglycemia and they didn't realize they had diabetes. So patients who are really symptomatic, need hospitalization, have very high A1Cs, blood sugars running in the 300s, or that group of patients where you think type 1 diabetes might be the actual diagnosis, not type 2 diabetes, those are all people to consider starting insulin. And just remember that starting insulin, especially for that patient admitted to the hospital, doesn't mean if they truly have type 2 diabetes that they have to stay on insulin. A lot of times you can get their blood sugars back in control and their beta cells can recover to a certain extent and they can even get off insulin. So this is just to get them under control to begin with. Otherwise, if you don't think that they meet this, instead of starting insulin first, if you have available GLP-1 receptor agonist therapy, then consider that prior to starting insulin. So I think the GLP-1 receptor agonists are becoming more and more available. Actually, this past year, there was certainly shortages in production. My patients, at least in Massachusetts, have not been having that much of a problem, but perhaps patients in different parts of the country might still find supply or expense an issue. So what about patients who are on therapy for type 2 diabetes, and now you're thinking, gee, is it time to add insulin? So this is really I would say, a judgment call, something to discuss with the patient. This has got to be, our new term is shared decision making. I think decision making was always shared because it's not successful if the patient doesn't agree to the plan, but this is definitely shared decision making. So times to at least consider it presented to the patient would be patients who are already on 2 or more medications, a combination. Their A1C is at least 0.5% higher than you would like it to be. And in your opinion, adding another non-insulin agent will not really bring down the A1C. So insulin, if taken by the patient, right, there's insulin resistance, meaning you need a lot of insulin, and insulin resistance, meaning the patient doesn't want to take it. But insulin can always be dosed high enough to work. It's just, having the confidence to increase the dose and trying to figure out how to get that to happen. So patients, again, on 2 or more on non-insulin medications, A1C at least 0.5% above goal, patient is interested in getting better glucose control, you can consider insulin. So what do you do with the other agents? In general, most of us would continue metformin. Sulfonylureas, that's a tough one. You could consider stopping it if you think they might get hypoglycemic. Sometimes blood sugars do go up. Certainly, once you are using prandial insulin, more than 2 shots of insulin a day, I think you would stop the SU. But this, again, is a little bit of a judgment call. DPP-4 inhibitors, SGLT2 inhibitors should be continued, no need to stop them. Just remember that even though they don't cause hypoglycemia independently, once you start putting them on insulin, they, of course, might get hypoglycemic. So you need to do some teaching as far as that goes. And GLP-1 receptor agonists, as long as the patient is tolerating it, everybody, I think, for the most part, would continue it. So what are we trying to do with insulin therapy? You know, I was talking about fast-acting insulin, basal insulin, slow-acting insulin. Here we have like the normal glucose excursions with meals and insulin excursions. So just remember, of course, that insulin is secreted overnight. Otherwise, we would all wake up very hyperglycemic. In the absence of insulin, blood sugars will go up. So that insulin is needed to keep the blood sugars in the normal range. But insulin has to be secreted naturally when meals containing glucose are ingested. And so that is kind of the natural pattern that we're trying to mimic. So how do we do that? This is just showing combining two types of insulin. This is a very common combination using the glargine to give you your basal insulin and either aspart or lispro to cover meals. And that can be quite successful in the insulin deficient patient. What about using NPH? So NPH, often if you're really trying to cover basal insulin, you would need to use it twice a day. I'm not sure, many of you may only have NPH as your basal insulin. So you can certainly consider using it twice a day and then adding, if needed, the rapid acting insulin with meals. So in terms of this, just this most insulin requirements are weight-based, meaning the smaller the person, the less they weigh, the less insulin they will need. And our heavier patients will need generally more insulin. So a standard dose, and there are many things that kind of make this be too little and other things that make it be too much, but a standard dose is 0.5 units per kilogram per day. And we tend to aim for giving half of that as rapid acting and half of it as basal, and this is close to kind of the natural way insulin is secreted. For older patients and those who have CKD 4 or higher, the dosing may be 0.3 to 0.4 units per kilogram per day. And again, getting to this concept of insulin resistance that I just mentioned, when you have insulin doses that are much higher than the weight-based dosing, like once you start getting up to 1 unit per kilogram per day, so a 100-kilogram patient who is on more than 100 units, start thinking, I would say a big cause is non-compliance by the patient. And so, you know, you really have to kind of look into that. And there certainly are physiologic causes for insulin resistance, medications, certainly steroid use can also contribute. And in general, trying to get the simplest regimen possible. So once a day basal insulin rather than twice a day, if it's possible, for compliance, for example, can be helpful. And this is the ADA standards of care for 2024. This is available for everybody online. It's free. You can just put in a Google search, ADA standards of care. There are multiple chapters on multiple aspects of management of diabetes, but this is one, initiating insulin. So if you know, they start out, if you think you want to start insulin to reduce the A1C, first, they want you to say, gee, could they be on a GLP-1 receptor agonist or the dual, which is tirzepatide, prior to starting the insulin? So you do have to have that thought, or if they're already on a GLP-1 and you still want to add more, their A1C is above target, you go with basal insulin, starting basal insulin. So you are going to try and do nighttime dosing, and it doesn't, although I should take that back. You do not have to do nighttime dosing. I think people do nighttime dosing so that there isn't confusion about taking basal insulin and breakfast insulin to cover the meal at the same time. Sometimes patients are very concerned about taking two different types of insulin at the same time and will not take them both. That's why doing it at night for the basal kind of gets away from that. Also confusing the insulins and the amounts. So they have their nighttime insulin and they recognize that in the daytime separately. But if we're doing the basal insulin, whatever time of the day that you are going to choose, that's going to work for the patient. Most patients, it's easy, start with 10 units. Depending if you feel, they're very small or they're very large, you may want to do it weight-based in terms of starting dose. And then you're going to set, and I know we have an algorithm that our nurses can use to adjust the dose, but you're going to set a fasting target for the patient to follow. So you can say, we want to get your fasting blood sugar to 120 or even 140. I would not target fasting blood sugars when you're initiating insulin therapy below 100. You can get there later, but I would not do that when you're just getting started. Because patients really get nervous if they get hypoglycemic and they'll kind of back off on you. And then what you want to do is give them a way to increase the dose. Here, the ADA is suggesting 2 units every 3 days. That is certainly a conservative way of doing it. And if they have any hypoglycemia, they should cut back the dose and be in touch with you. I always give them an upper dose. We've had patients not do the injections properly, and they think they're giving the insulin, and they're really not. And so if they keep going and they have no progress and they reach a certain dose, let's say you tell them if you get to 30 and there's no change, give me a call, then you can at least go over technical issues with the patient. So once you get their fasting blood sugars to where you want them to be, then you have to say, have they reached their A1C target? If they are not on a GLP, one receptor agonist, can you add that at this point to try and get them? Or do you need to add prandial insulin? So these are always tough choices. Hopefully, if you have a diabetes educator to work with the patient, it makes it easier. But this is just giving you some idea of how to start prandial insulin. Usually, we start just like it says here, have them start with just 1 meal a day so it's not too overwhelming, and that they get used to 2 different types of insulin, and then they increase slowly until you get to goal. And again, if they get hypoglycemic, you have them back off and contact you. And then this actually really is just going into all the different ways you can do this stepwise and have it at 2 meals or 3 meals. I'm not sure how many people are self-mixing anymore. I put this up here. I think that's a little bit old-fashioned because anyway, we're pretty much on pens, and so you can't really mix in the same syringe anymore. But I'd be curious whether some of you are in situations where you are using vials of insulin that can be mixed together, and then you have to be careful as to which ones are compatible for mixing in the syringe. So this is giving you some idea of how to do it with NPH for those where NPH, being so much less expensive, is still being used. And again, twice daily premixed insulin is certainly easy, not necessarily achieving the best results. So I have two cases I wanted to go over, and then we should have time for questions. So these will be kind of quick, and it's more for a discussion of what you think you would do in the situation. These are very common situations. Actually, I'm very happy because I can see that we have a lot of participants. So people certainly can put in ideas in the chat, but I just want you to mostly think about it. So this is very typical. 64-year-old male, 20-year history of type 2 diabetes, comes in with an A1C of 9. It's got a BMI of 30, weighs 190 pounds, currently on glipizide, metformin, and dulaglutide. He does his blood sugar monitoring once a day, averaging fasting around 160. He has no complications, so he has normal renal function, and he agrees to start insulin. So what would you suggest? I have a couple of thoughts. Okay, so these are, in my opinion, a couple of things that all of us would think about. So would you say, oh, why don't we try going up on the dulaglutide to the maximum available dose, which is currently 4.5 milligrams a week. I could also say, or switch to tirzepatide, could go there. Don't start insulin, instead add empagliflozin. Start insulin at 10 units a day. As I showed you, continue all the other meds. Start insulin 10 units a day and stop the glipizide. Start insulin at 10 units a day, stop the glipizide, and have the patient self-titrate the dose according to some of the suggested ways by the ADA. So I think that's most of our various options. And one thing I want to emphasize with this, in my opinion, there isn't necessarily there. In fact, for sure, there isn't a single answer. I think we could do this. I think people could do a couple of things, and maybe just because it's kind of hard to actually have people say what they would do, I would say just starting the Lantus, continuing all the other meds and not doing anything else. Probably not enough. It's probably not going to do anything at 10 units for somebody that size. And so that would not be enough. I think for both of these, if you're going to do this, you would have the patient has to self-titrate the dose. So that's one thing. I just want to make sure that you know that these are starting doses, and they the patients will need to adjust the dose. Adding the EMPA, I would say the empagliflozin is great for patients who have kidney disease, who have cardiac disease. It is not great for lowering glucose. So if you're really looking for effective glucose lowering, probably SGLT2s not enough. Increasing the dulaglutide, that is the easiest, right? Try that, see how he does, see if it's enough, or now adding tirzepatide. That would be it. So I would say you can either do the insulin and titrate the dose, or go with the GLP-1, higher dose, see how they do, and then come back to doing the insulin. So we'll see if you guys agree with me. But my main point is, you could think about some of these other things. I just wouldn't start the patient on insulin, leave them on a low dose, and not have them titrate up. I think that's the only thing that I would say would probably be inadequate. It's unlikely to solve the problem in any case. So let's look at another one. 70-year-old patient, 20-year history of diabetes, A1C of 9, BMI 27, She has more chronic kidney disease, GFR of 35. She's already on glargine 50 units and pagl and 10 milligrams a day. She tests her blood sugar about once a day, random times, averaging about 150. She says she's going to cut back on carbs to improve her A1C. So she ends up, so this is not that uncommon. They're going to cut back on carbs. They're going to have a good lifestyle, blah, blah, blah. Bump. She goes to the ER with a blood sugar of 40 after all she had was a salad for lunch. Then they send her, they say, go to your PCP tomorrow and he or she will tell you what to do. So the patient shows up in your office. After breakfast, you do a finger stick and it's 250. Okay, so, this is a more complicated problem. So what are some of your management options here? You can add metformin to the regimen and say, gee, she's not on metformin, 2,000 milligrams a day. You can tell me what you think about that dose. You can stop the EMPA. You can start semaglutide. You can start mealtime Lispro, 5 units AC, because her A1C is high and her blood sugar in your office is high. Or you can drop the glargine to 40 units. So, so again, as far as this case goes, I mean, my philosophy has been get rid of the lows. So if somebody has a really serious low blood sugar, you can try to counsel them. She wants to really cut back on carbs and you want to encourage that, but you also want to make sure she doesn't have such a serious low. So I think you have to have a discussion. If it's a one and done situation and it's never going to happen again, maybe not cut the glargine, but you do have to have that discussion. And if patients have blood sugars that are, an elevated A1C, but they're still having hypoglycemia, then you have to get rid of the lows before you start making other changes, especially in an older patient. For this, metformin, 2,000 milligrams a day is too high a dose for that degree of renal insufficiency. No reason to stop the EMPA. Certainly, you could consider starting semaglutide if she wanted to, but you would also cut back on the insulin. And I don't think at this point, until you get things better straightened out, you would start mealtime insulin until you knew she was not going to be having lows. CGM is very helpful to see if she's having unrecognized lows. She's only testing her blood sugar once a day. So you could consider doing some CGM if you have that available. Many people might not. So just in conclusion, hopefully you can understand how the different types of insulin are related to their different structures, and use that information to try and figure out the best insulin for your patients. So often we have to combine the insulins with fast acting and basal insulin to achieve physiologic control. GLP-1 receptor agonists, if they're available, if they're affordable, should be tried first if there are no contraindications. In my opinion, you should have the simplest regimen possible and try and eliminate low blood sugars before you work on the high blood sugars. Okay. So I think here, should I stop
Dr.
sharing?
Hudson. Yes, you can stop sharing. Thank you so much for sharing all of that information with us. And I wanted to welcome any questions. Probably easiest to put it in the Q&A icon on your Zoom toolbar. And we'll start off with this great question. Could you address the common regimen of basal insulin plus sliding scale rapid acting insulin?
Okay, so rapid, sliding scale. This is really, it depends on how you do the sliding scale. So if a patient is on basal and you think that the basal dose is reasonable and you're doing sliding scale because they get high during the day, then you're really doing mealtime insulin. And I think it has to be dosed not just as a correctional factor, but also to take into consideration the carb factor. So, so this would be for a more insulin deficient patient. And what happens is that we say, oh, if your blood sugar is 200, take an extra 3 units or something like that, without taking into account whether they're going to have a pasta meal or they're going to have a salad. And so it won't really cover the meal if it's just correctional insulin. So I tend to, if you're going to use correctional insulin, you probably use insulin to cover the carbs in the meal as well. I don't know if I got to that question or not. I'm not a big fan of sliding scale.
Thank you. I can tell. That's okay. And if there's any if there's any clarifying questions from that person who posted, please feel free to add some additional questions for clarification. The next question, when patients on long-acting insulin like glargine need to fast for surgery, what percentage of the basal insulin dose do you keep them on?
Okay, so that's an excellent question that everybody asks, and it's really, really hard. So I think you have to know your patient, right? If they are in general running high all the time, right? Then you may feel, oh, they don't need to cut back quite as much. If they are running low, and they have very good blood sugar control, you might be more concerned because the Lantus is going to last all day. So they're going to go in the morning. Let's say they tend to wake up with a fasting blood sugar of like 90 or 100. That Lantus is in their system all day and will tend to drive their blood sugars down. So you want to cut back on the insulin so that they don't get low during their procedure. And so that patient, the patient with kind of tighter control, I think you would cut back, maybe even as much as between 50 and 70%. And what we do is make sure they get a finger stick when they arrive for the procedure. And if it is in the range of 100 or certainly less, that they start a D5 drip. So that I think you can make up for them taking too much by having them test a finger stick. On the other hand, you have the patients who are not in as good control, and they're a lot harder to know what to say. So because you don't know, are they not in good control because they're not on enough insulin, or are they not in good control because they wake up at 2 in the morning and have a bag of chips that they don't tell you about? And now they're going to have their procedure and they're really not going to have their bag of chips. So all of a sudden, the insulin that they're taking may be sufficient. So this is where you have to use your clinical judgment a little bit more as to whether, okay, they are a night snacker, they're not going to be snacking, so then I'll do more, cut back to the 50 to 70%, or they are just not well controlled. I'm not as worried. I don't want them to show up with a blood sugar of 200. Sometimes the surgeons, depending on the procedure, they aren't going to want them to have the procedure if they show up with too high a blood sugar. So then you would maybe only cut back to 80%, cut the dose down by 20% in the more poorly controlled, chronically hyperglycemic patient, in part so they don't show up with too high a blood sugar. So in that sense, I think pre-op management guidelines are very, very hard to write and do require somebody who really knows the patient well. And also it's very, very helpful if they can do a finger stick right before the procedure and add on glucose if they, are at risk, and especially with a longer procedure. Okay.
Great. Thanks, Dr. Hudson. It's really an art and a science for sure. We'll take this one final question. I know that we're already at the top of the hour, but like to address this one. When you say GLP-1 RA should be tried first in type 2 diabetic patients, do you mean after metformin or as first
Oh,
injectable medication to use?
okay. This was when you're thinking about insulin, right? If you're thinking about starting insulin, then think about doing a GLP-1 before you start insulin. If you're with a patient who isn't on anything, then this becomes a brand new discussion. Should they be GLP-1, metformin? In the old days meaning the ADA guidelines of 2023, at the top, it was always start metformin first. Now, if you look, they've taken that away. I know that Dr. Snow and Dr. Pendergrass are going to be talking, I think, next week, just exactly about, metformin has been demoted a little bit. So now if there is like a cardiovascular indication or whatever, you can go straight to a GLP. So in general, if you're thinking about insulin, I would think if the patient, that I'm assuming the patient's already on metformin, if they are a metformin candidate, if they tolerate it and their renal function is sufficient. But otherwise, yeah, metformin, GLP-1, which one to go with first? I think now you can use your judgment. All bets are off. We're getting away from a defined algorithm, start here and add this, add this, add this. And instead, it's more kind of, you have these options based on various patient characteristics. I hope I answered that.
That's great. Dr. Hudson, thank you so much for presenting to us today. A huge shout out to Cherokee Health Systems for being our host clinic for today as well. And a huge thank you to all of the MAVEN Project clinic partner providers for all of the work that you do caring for your patients. Just a reminder that our MAVEN Project volunteers are willing to support you and receive consults from you on our telehealth platform. If you've never used the platform before and you already have an account but need some help, please reach out to us and we'd be happy to take you through it to get set up, or ask somebody in your clinic who may have already used the MAVEN Project platform. But we have 200 volunteers and 60 different specialties here to help you with your patients. So I hope everybody has a great day. Thanks, everybody.
Bye.